Okay, thank you very much. The professor was trying to talk me into going and having some lunch right now, and it does sound very good, but I'm so excited to give this talk about limb length assessment that I talked him into having lunch after that. And thank you, Nadav, for an excellent talk on the predictions, which is normally part of this talk that I give, but I took that part out because you did a much better job than I could at doing that. Oh, I'm doing the wrong mouse here, excuse me. So the main objectives of this talk are to give information on how you can really accurately measure limb length discrepancy and how we can communicate that between us. And I'm going to try to hit this point on this graph right here, not giving too much information to make it complicated and confusing, but not giving so little that you end up being confused as well. So we're going to have just an intermediate amount of information in order to be able to really accurately assess and communicate limb length. The prevalence of limb length discrepancy in the normal population is almost a third of normal people, and so many of our patients are really obsessed about having 5 millimeters of difference in length, and you have to explain to them that up to a third of people have 5 millimeters of length discrepancy, and even 4% of the normal population has 1.5 centimeters of limb length discrepancy that they oftentimes don't even know about. And beyond that, I guess we wouldn't really call them the normal population. And the significance of limb length discrepancy up to 2 centimeters really has not been proven. Patients with less than that have not been reliably shown to have higher rates of low back pain or hip mechanics. There was a study where they artificially lifted one leg 2 centimeters with a shoe lift, and the participants in this study showed increased oxygen utilization for activities. But there's really little evidence to support treating limb length discrepancies less than 2 centimeters. That's not to say that you will never see a patient that is not symptomatic, and I think it's okay to treat them if they're truly symptomatic. The smallest discrepancy that I've lengthened, it was 16 millimeter discrepancy in a girl that had a low back pain. She really felt like it was due to the limb length discrepancy. And so I said, well, let's give you a shoe with a 16 millimeter lift on it, and you wear it for 3 months, and let's see what happens. And she came back, and all the symptoms had completely resolved, and she said it was absolutely perfect. And we went ahead and lengthened her leg so she wasn't dependent on a shoe lift. There are some adverse psychosocial effects shown in patients with more than 2 centimeters, and not everybody with more than 2 centimeters limb length discrepancy will have these problems, but they can occur with a higher frequency. Of course, it's important to get a history to determine where the limb length discrepancy potentially has come from, and then to do a thorough physical exam, including looking at the skin for cafe au lait spots, which can go along with neurofibromatosis, congenital pseudoarthrosis of the tibia that we're going to talk about, examining the range of motion of the joints. We talked about how that affects children with congenital short femur, looking for joint stability, and the limb length assessment is also combined normally with the limb alignment, which is a completely different talk that we're not going to go into today. And then having the patient walk. And I always have the patient walk down the hallway, and it's surprising because some of them tell me, well, wow, I saw another doctor and he didn't even have me walk. But this is the easiest thing that you can do, and the patients think that you're doing a real thorough exam when you watch them walk. Sometimes you watch them when they're just walking into your clinic ahead of time as well. There's a couple different clinical methods, several different clinical methods for examining limb length discrepancy, and one of those is the umbilicus to the medial malleolus technique, but that really doesn't differentiate actual leg length discrepancy from an apparent leg length discrepancy. And if you just measure from the umbilicus, it can measure not differentiate those people that have a contracture of their adductor muscles. And so it's important to go from the anterior superior iliac spine to the medial malleolus if you're going to use a clinical measuring technique. A lot of this we don't do anymore because we have good x-rays on the EOS scanner and can get very accurate measurements. But if you are going to do it clinically, the method on the right is the one to do, because you can see how the adduction contracture can make a leg length appear shorter than it actually is. You can also have the patient lie on the exam table, and then you're able to better differentiate the tibia length from the femur length. And also prone exam is helpful as well. So the radiographic assessment has advanced and evolved over the last few years. Many of our centers in the United States have the EOS scanner now, which is a slot scanner that takes an image scanning down over a period of about 5 seconds from the hips, or you can set it to start at the neck and get scoliosis exam as well. And this is a slot x-ray that scans down over this period of time, and there's no magnification for longitudinal measurements using this scanner, and it's very good for getting really accurate length measurements. If you try to measure the diameter or your canal diameter, it does not give you good measurements for that, because you can see that the magnification is still present in the horizontal plane by the way that slot is designed. Another advantage of this system is that it scans the AP and lateral view at the same time. So your patient with a small knee flexion contracture can't move their knee in between the AP and the lateral view, and so you can check your lateral to make sure that the patient wasn't bending their knee or some other discrepancy throwing off your measurements. And these images, since the AP and lateral is being scanned at the same time, can be processed to provide some rotational information as well, and fine-tune rotational corrections in the femur, as well as some three-dimensional scoliosis imagery that we use it for. And perhaps one of the biggest advantages of this system is the X-ray radiation is much lower than traditional X-ray, with scan protocols giving only less than 1/40th of the radiation of a normal X-ray. And because of that, the image quality is a little bit more grainy. It's not quite as high quality, but that's okay for us, and most of the time when we're trying to just measure length. We're not looking for bone quality or regenerate quality, and sometimes in cases that are undergoing lengthenings where I need to see the quality of the regenerate, I also have to get a normal X-ray to be able to see that regenerate. So if somebody has a tumor or something, this is not an ideal type of technology to really look at the quality, but rather the measurements. The patients need to be able to stand up to be scanned. They must fit in the scanner. We have a few people that are so large that they can't fit in the scanner, but you really have to be big to not be able to do that. And you need to be able to hold still. If they don't hold still, there's some waviness in the image that can throw off your alignment measurements. I'm going to introduce a terminology to you that I use for measuring limb length, and it's been helpful in a number of ways that we'll discuss, and that's looking at what I call global versus segmental analysis of the limb length discrepancy. So the global is just an overall picture of whether or not there is a limb length discrepancy, and it basically quantifies it. And the segmental measures the individual segments so we can identify where that limb length discrepancy is coming from. Those of you that know about the limb alignment measurements and how we measure the mechanical axis deviation, this is a similar concept to looking at the MAD, determining if there is a deformity, and quantifying that to some degree, and then we go on to the next steps to determine where that's coming from. So the ultimate goal for us, I suppose, is to be normal. Maybe not for all of us, but normal in the limb length discrepancy world means having a level pelvis. So technically speaking, this frequently is the same as having level femoral heads, and we oftentimes use the femoral heads to determine whether there is a leg length discrepancy, and that's okay, but there are some cases that have pelvic obliquity. Patients have had previous pelvic osteotomies or have deformities that can give another segment of limb length discrepancy, and that does need to be looked out for. So it's easier, though, to just measure from the femoral heads, and that's mostly what we do, but this base of the SI joints is the true foundation for a level lower extremity alignment. The global limb length discrepancy is just a screening exam. It will tell you the overall difference, and this is oftentimes just using the femoral heads if there's no pelvic obliquity. So if these two lines are parallel, from here on out you can just use the femoral heads. And in this case, if we're looking at a global limb length discrepancy, we can see that there's no pelvic obliquity, so we just use the femoral heads. And to determine the amount of limb length discrepancy, simply drawing a horizontal line on your screen and then measuring the distance to the contralateral femoral head is really the most accurate way to determine a limb length discrepancy, just the global overall limb length discrepancy. If you measure down to the ankles, sometimes patients can have different foot height, and just measuring the length of your tibia plus femur may not take into account all the different areas where a limb length discrepancy can arise. So I typically like to write my numbers on my charts in millimeters because I don't have to worry about the decimal points, and it's nice and accurate. And instead of saying plus or minus and this one's more than that or less, I just put an R or an L next to the side that's the longer side. And so in a case like this where the right leg is longer than the left leg, we have 30 millimeters longer on the right side, I would write global LLD 30R. That's 30 millimeters longer on the right side. Once you've looked at the global, you can look at the segmental and measure each segment. So if the pelvis is already level, you don't have to do the red part, and then you can proceed to measuring the femurs and the tibias. And the global and segmental should add up to be the same thing, except for in a couple scenarios, like this one right here, where you may have segmental lengths. In other words, the tibia and the femur are both the same length, but your global height is different. And some of us have wondered, in correcting a deformity like this, if we should do an opening wedge or a closing wedge, and if the patient's really going to have equal leg lengths after you finish your correction. And if you compare the segmental and the global, you can see how much difference there is there and know how much you need to gain when that deformity is corrected, and it can help you make those decisions. So even though there's a femoral head height difference here, when we measure the segments, there's really no limb length discrepancy. So how about sagittal plane deformity or joint contracture? Global and segmental length should be equal on the AP x-rays, and we should use, in other words, if the patient has a knee flexion contracture, then it may look like when their knee is bent that if their right knee is bent, it may look like the right lower extremity is shorter, and in that case you need to look at the lateral x-ray to measure your segmental lengths and get the true measurement for segmental. Because if there's a knee flexion contracture or an ankle equinus contracture, then the global and segmental values will be equally reduced, and you may not pick up that secondary deformity unless you're really examining the lateral view. And what if there's pelvic obliquity? How do we actually deal with this when it's present? So here we see it's a bit subtle. You don't always notice it, but we see that the right side of the pelvis is a little bit longer than the left side from the SI joints. And if we just measure at the SI joints, there's not going to be a really significant difference between the two. So we need to measure the difference between the leg lengths by using the mechanical axis of the lower extremity, and where that mechanical axis intercepts the line that goes through the SI joints is where you measure your true global limb length discrepancy. So if we measure it right at the SI joints, that difference is going to be less than what we measure here in a similar fashion to how we're measuring the femoral heads. So When these x-rays are taken, it's very important that the patient is weight-bearing equally on each side, and it's important to talk to your x-ray tech frequently about this because they don't always do this, or the patient's wearing a shoe and it's got some tissue inside of it to elevate the leg a little bit more, and if you don't know about that, it can throw off your alignment. The patients need to have their knees straight and make sure that there's no equinus contracture. I have our techs in the habit of, when the patient needs to have a lift in order to weight bear equally on both sides with their knees straight, then they put a lift under the shorter leg, but they just put it under the heel, because then if there's an equinus contracture, it doesn't elevate the heel off the level of the shoe lift and throw you off. In this case, we measure the global limb length discrepancy, and then we also calculate the lift to get our number for global limb length discrepancy. And if the tech has actually leveled your hips exactly to the same level, then the limb length discrepancy is just the amount of lift that's under there. It's not necessarily the goal that your tech has to make your femoral heads exactly equal. Their goal is that the patient can put weight on each side equally, and if there's a discrepancy in the height of the femoral head, then we can calculate it like you'll see in the next case here. So on this case, there's a 4 centimeter lift under the right side, and the global difference here is 15 millimeters. And so there's a total limb length discrepancy in this case of 55 millimeters. And we write that 55L because it's 55 longer on the left side. Sometimes the tech can put a lift in that's too big, and then the short side is lifted too high. And in that case, you simply subtract the difference of 15 millimeters from that 4 centimeter of overlifting, and you can note that the global limb length discrepancy is 25 longer on the left side. Or they'll lift the wrong leg altogether. And if they lift the wrong leg, then you can see that when you measure the global difference and you get a number of 30 millimeters, that if they've lifted the opposite side 2 centimeters, that in reality, in this case, the left leg is still 10 millimeters longer than the right leg. So in summary, for the global analysis, don't forget to check pelvic asymmetry. It can be subtle. It's not necessarily noted. Draw 2 parallel lines, and then you're good to go from the femoral heads. Another pitfall is to be aware that the patient is standing with one knee bent. And when you see an AP x-ray that looks like this, where one leg is so much shorter than the other leg, you automatically suspect that the patient may have been bending a knee, because how could anybody stand with that much pelvic obliquity? And so you want to look on the sagittal plane and measure your segmental lengths on the sagittal plane. This is an example of some bad images that it's important that your x-ray department is really close to you, because you need to talk to your technician every time about this if it happens, to train them to do a better job. They put a lift on this patient that you're seeing on your left side, and they didn't note how much it was. So you really can't measure the limb length discrepancy in this patient if you don't know how much the lift was, because foot height can vary pretty significantly. And on the other x-ray here on the right, you see the ton of pelvic obliquity, and this patient most likely is either bending that long leg a little bit to weight bear equally, or he's not weight bearing equally, and the feet aren't clear down on the ground. Perhaps he can stand that way if he's really flexible, but there should be a lift put under him to make him be able to stand a little bit more comfortably. So positioning for the x-ray again, the 4 key points: that they have a more or less level pelvis, they put their weight equal on both sides, make sure the equinus contracture is not affecting you adversely, and take off the shoes. These patients, they always hide something in their shoe, and the tech doesn't always know if it's there. So when we measure the femoral segment and the tibial segments, just a little tip is to go from the top of the femoral head to the center of the knee. With the limb alignments, we typically go from the middle of the femoral head, but for the limb length, make your segment the measurement from the top of the femoral head to the middle of the knee. And then the tibial height goes from that same point in the knee down to the tibial plafond. And you should measure it right down the center to the center of the knee, not over the medial femoral condyle or medial tibial plateau or something like that. So in a situation like this, these measurements are not ideal because the femur length is overlapping the tibial length a little bit on the right leg. There's a little bit of space between those two lines on the left leg. And so I would encourage you, when you make these measurements, to do it like this, where your femur length is going right down to the same point as your tibial length. And on the right side, I put not ideal here because you can see that the femur is measuring a little short and the tibia measuring a little bit long. But overall, the segmental length of your femur plus your tibia is still going to be the same as what it would otherwise be if your point was exactly in the center of the knee. So you try to get your point exactly in the center of the knee, but make sure wherever you put that point that your femur ends at the same place that your tibia begins in order to have the most accurate measurements. And if you'd make a point right in the center of the knee and then draw those lines to it, that's helpful. And then the fourth segment is the foot height. So the first segment's the pelvis, the second is the femur, third tibia, and the foot height is the last one. And usually we just measure to the bottom of the x-ray, and it's not an actual foot height, but because we don't know where the bottom of the x-ray is cut off, but it does give us a good relative value. And when you measure the tibial plafond, you can draw a horizontal line and then measure the distance up or down to the opposite side in order to get the foot height difference. So that's similar to the way you measure the femoral head height difference. It's easier to make a horizontal line and then measure that little difference than it is to measure down to the bottom of your x-ray. Oftentimes on the x-ray systems, you measure down to the last pixel on your x-ray and it flips to a different screen or something else happens and it's a little bit more difficult. So in this case, the right foot is 10 millimeters higher than the left foot, and we just document foot height as 10R. And if the feet height are equal, then you can just leave it out of your segmental analysis. And in a case that we see here, the one on the right side is 4 centimeters higher than the one on the left side, but we have a 4 centimeter lift, so the feet height are the same. And so to summarize this technique for measuring the different segments, pelvic height is the red area, the femoral height, the green, and then purple, then blue, and then purple. And those should all add up to your global unless you have a significant varus or valgus deformity. And in this case, if you have your knee bent, like this patient may have had the left knee bent, it's going to equally decrease your global and your segmental analysis, obligating you to really do a good exam on the lateral view. Here's an example. So we look at the inferior aspect of the SI joints. They're parallel to the femoral heads, so we can use the femoral heads to measure our global limb length difference, and we have 21 millimeters on the left. The left side is longer than the right. And then we look at the segments, and this is how I document on my chart the segmental differences. We have the right and the left, the femur and the tibia, just as they appear the patient on the x-ray, just as you're looking at me, right femur, right tibia, left femur, left tibia, and write those numbers in there in millimeters. And then on the side margin, the left femur is 2 millimeters longer than the right. You put a 2L. The tibia, 16 millimeters longer on the left. It's a 16L. The foot height is longer on the left, and that all adds up to 21L segmental difference. We see the global and the segmental are equal to each other. That makes sense because there's no significant coronal plane deformity. So you already heard this talk about using the multiplier method for a lifetime plan. Really well done and important. And this morning I mentioned that we developed this app that we have on our workstations in our clinic. And it basically does the same thing that the multiplier app does, and I have the multiplier app. I use it commonly. But this spreadsheet does have just a couple advantages that I want to point out. First of all, it can be on your workstation, so it's easy to cut and paste into the record. And secondly, we use right and left instead of short leg and long leg, because there's been a few occasions where I've had a patient with a limb length discrepancy that's growing and over-lengthened the short leg a little bit, and then when you go back and try to program the short leg that's now the long leg, when you're using the short long leg terminology in the app, it can be a bit confusing. And so this keeps track of those, and the previous lengthenings section there is helpful because we can just free type in when the surgery date was, and then put the length that we lengthened at that time under right or left. And that actually programs into the mathematical formula to affect the limb length discrepancy. Because if you have a patient with a given limb length discrepancy and they've had a previous lengthening, then your predicted amount is going to be different than it would if that was their natural amount of limb length discrepancy. And then at the end, it will give you suggested timings for epiphysiodesis right there without having to go backwards on the app and re-enter your numbers in to know when you might want to do an epiphysiodesis. And we also have pages for predicting the adult height and for using developmental limb length discrepancies in there as well. So if anybody wants that, it's published in the Journal of Children's Orthopedics as well, but you can upload the copy of that. It's just an Excel file. There's nothing too fancy about it. We followed the color scheme of the multiplier app out of respect for the Baltimore group and the awesome app that they made. So here's one more case example where we see a patient with no pelvic asymmetry. This was a case that I showed you just a few minutes ago. Now we see that there's a global difference of 20 on the right side, but when we measure the segments, then we see that there's no limb length discrepancy. So this is a case that there's no limb length discrepancy between the right and the left segments, and you want to do a neutral wedge type of correction. So that might be like a dome osteotomy or an open and closing wedge osteotomy to get exact limb lengths restored at the end of that correction. So when you do have a disagreement, there's either a coronal plane deformity or there's been a significant varus or valgus around the knee, or you might have measured erroneously. You need to double check your math and your measurements in that case, because there's really no other scenarios that there would be a major disagreement between your global and segmental. Here's another pitfall. This patient has fibular hemimelia with some mild congenital femoral deficiency, and there's a 9 centimeter lift under the left leg, and the foot height difference in this case is 11 centimeters. So here we have the short leg on the left side, and the foot height is 2 centimeters longer, or taller, I should say, than on the long leg. And that's extremely unusual and unlikely, because typically patients with congenital short femur or fibular hemimelia have a foot height that is decreased on the same side. And so you need to think about how this may have occurred. And in this case, it ended up being an equinus contracture because the tech didn't put the heel on the lift. They put the forefoot on there. She had a significant equinus contraction. It really threw me off because here we think that there's only 9 centimeters of difference plus the 2 centimeters that are up above is like 11 centimeters of overall limb length discrepancy, but it ended up being a 13 centimeter limb length discrepancy, which is a significantly more difficult issue to deal with. So make sure that the tech appropriately marks that they don't have equinus contractures affecting this, that they're weight bearing equally. And pelvic asymmetry can be a challenge. This is a case that had a hemipelvectomy, making it more difficult for us to really assess limb length discrepancy. And the stiffness of the hip can affect fixed pelvic obliquity, which you have to be careful of when assessing limb length discrepancy. But the bottom line in a case like this is that we have to remember that our ultimate goal is to have the inferior aspect of the SI joints be level. So in summary, the global limb length discrepancy measurement is a screening exam. It's quick and easy. It quantifies the amount of discrepancy that's there. And then the segmental divides that down and confirms where it's coming from and confirms that you measured the global correctly. When they don't agree, you want to check your math, check your measurements, look for any varus or valgus. And be careful of other pitfalls. Be careful of when the patient's standing with a knee flexed. If there's significant sagittal deformity, like anterior bow of the femur, can affect this. If they're not bearing weight equally, hiding things, unmarked lift. Lift marked wrong is another one. Sometimes they put a 3 centimeter lift and it can only be a 2 centimeter. So you always want to examine your patient. You'll always get a lateral x-ray and make sure you communicate with your x-ray tech. Thank you. So the question is, if you have like a fixed lumbar obliquity creating your pelvic obliquity, and it's forcing the patient to feel like, let's just say, for example, that their left leg is shorter because their pelvis is oblique, should you perform a lengthening of their left leg so the patient will feel normal, even though you already know that their leg lengths are the same? There's not a right and a wrong answer to this. I think if it's a recent onset type of issue that created this obliquity, that it's not good to give them a lift on that side and not good to try to make them feel leveled, because many people will get used to having a limb length discrepancy if you just let it be for a while. And so it's good to encourage their body to try to become more symmetric, and if we just lift that leg, it kind of encourages the opposite. But if it's been a long time and it's fixed and there's no chance of it really correcting itself, I think that thinking of lifting them, first of all, just do something temporary to see how they feel with it, like a shoe lift. And starting with something that's about half of the difference is a good place to start, and then see how they feel with that. And ultimately, if they really feel a lot better with that, I use kind of the 3-month rule. Take careful notes of what they're telling you, and if they're really consistent and if they come back in 3 months, then you can think about doing something more permanent, more definitive for them. Did that answer the question more or less? If there's any other questions, happy to have further discussion as well, but otherwise we'll go on to Dr. Rather and another exciting lecture.
Thank you.